Rahim. Thank you very much for a nice introduction, and thank you to the organizers who have invited me to this occasion to speak. I hope majority of the people are still awake after taking a very delicious food, and they will be attentive. I will briefly talk about psychosocial aspects of rheumatic diseases. There is a close relationship between all sorts of rheumatic diseases and psychiatric illnesses. There has been numerous studies that show quite varying prevalence of psychiatric illnesses in rheumatic diseases. But general consensus is around 40 to 50% of the people suffering from any of these rheumatic diseases, they suffer from any of the psychiatric illnesses like depression, like anxiety, adjustment disorders, and almost all face some lifestyle changes. And the most common psychiatric disorders encountered in rheumatic diseases are depression, anxiety, adjustment disorder, and especially so in SLE, where we also confront psychosis and delirium. And the lifestyle changes include changes at work. In this competitive world, majority of the employers will have healthy employees. And if someone suffers from a rheumatic disease during his course of work, he will definitely face certain difficulties. Maybe he is sacked from the job, maybe he is degraded, maybe he is personally feeling difficulties in reaching to the workplace and coming back and to conduct through his whole day work. At the same time, a person who is suffering from any of these painful, disabling rheumatic diseases will have family problems, and he will face, or she will face, relationship problems. Less time he will go out and enjoy his leisure activities. Social participation will be decreased. And then in rheumatic diseases and drugs used in the treatment of rheumatic diseases, especially so in SLE, there are concerns about sexuality, marriage, and reproductive life. SLE is a very serious chronic disabling illness which goes on. It starts in the early age and it rests with the person throughout his life. And during that, he will often have periods of flare and acute exacerbation. And during those periods, the person will suffer from psychotic episodes. He may go into delirium, and long-standing effects of such illness will result in cognitive denial. And then there are mood disorders, anxiety disorders, along with all other rheumatic diseases. And more so with SLE, one need to plan a whole life with this disease. What to study, where to job, what to job, when to marry, when to have children. All these aspects are very, very important. And we, as a doctor, should look into all these areas and counsel the patient regarding these issues. As I said, there have been many studies about the relationship of psychiatric illnesses and rheumatological diseases. To my mind, the relationship is two-way. Many of our patients who are suffering from depressive disorders or anxiety disorders, they have multiple physical aches and pains, which can mimic the symptoms of rheumatological diseases. And on the other way, almost all rheumatological diseases cause pain and disability and results into any psychiatric issues. When I was going through the literature to look for the information, I came across a textbook chapter of, say, 1960 or 70. There, rheumatoid arthritis was classified with psychosomatic disorders, along with bronchial asthma, ulcerative colitis. And in fact, during those days, because there was lack of knowledge about the real etiology of rheumatoid arthritis, there are many speculations. many people think it is a psychosomatic disorder. And the studies conducted during those days, they in fact showed a very close relationship between psychological disturbances and then the onset of rheumatoid arthritis. We often use MMPI, multiphasic personality inventory, and there was a very interesting study which showed quite a high level of disabilities and sufferings, those people who later developed rheumatoid arthritis. So people really believe that it's a psychosomatic disorder. But from then onward, we have moved forward, and now it is no doubt in anybody's mind that rheumatoid arthritis is a biological disease, but with many consequences which are related to domains of, say, cognitive domain, affective domain, and many of the patients, they suffer from anxiety and depressive disorders. This is one quite recent study which is very interesting to my mind. It included 50 people, 25 of them were suffering from active rheumatoid illness, and 25 age-controlled healthy people. And they followed them up for 6 months. What they found, whenever there was a flare in rheumatoid arthritis, and the proportion of the people having that flare will have more depression. And overall, during 6 months, they found out that 80% of those patients suffering from rheumatoid arthritis, they had clinical depression. And 52% of the patients, they have clinical anxiety. And the correlation was highly significant at p-value 0.001. While the healthy control, 8 of them have depression which was only mild. We as a psychiatrist do not actually know the pinpointed etiology of depression. There have been many hypotheses, and the more accepted theory is monoamine hypothesis, which says that there is some deficiency or underfunctioning of monoamines in our brain, more so the serotonin. But there is information that people have started thinking that depression itself is an inflammatory disease, and there is evidence to believe that. Depression is associated with the chronic low-grade inflammatory response and activation of cell-mediated immunity, as well as it is accompanied by increased oxidative and nitrosative stress working as mediator between biological factors and personal and environmental factors. And there is another evidence that cytokine infusion, if given to people, they develop classical prototype symptoms of depression. And interferon, when it is used in the treatment of hepatitis C, around 40% of the patients, they have clinical depression warranting discontinuation of treatment. All these biological things, they indicate maybe someday we will find very clear evidence that depression itself is an inflammatory disease, and then we will be in a position to understand this relationship better. Rheumatoid arthritis and other rheumatic diseases, they are commonly associated with pain and disability. And that pain and disability results in psychosocial factors, psychosocial sufferings, and that psychosocial suffering in return change our perception of the pain. And this way, this cycle of suffering goes on, and the patient keeps on suffering unless we address the main causes and we also address the psychosocial factors. We are not supposed to treat our patients about their main illness. We are supposed to look after the patient's total well-being. And because of that, World Health Organization has defined health as health is not merely an absence of disease, but a complete physical, psychological, and social well-being. And now, keeping this definition in mind, I am afraid very few people will fulfill this criteria of being healthy. So, even if we do not fulfill this criteria, we should try to achieve close to that. And how to manage such patients who are suffering from rheumatic disease and at the same time are entering into a vicious cycle of pain, disability, and psychological disturbances. For that, I think biopsychosocial model should be the mainstay, and in that we should look into the biological factors, we should look into the psychological factors, and should consider the social factors as well. And for that, we need a multidisciplinary approach. Culture aspects play a very significant role in the management of any illness. As Dr. Aflaq mentioned in his presentation, many people do not have a proper information about the illness. So, the patient should be taught about, counsel about all these things, and then through the multidisciplinary approach, all the issues regarding the illness and associated problems should be addressed so that we can come closer to the ideal target of absolute health. Management, the mainstay of the management obviously will lie with the rheumatologist, and they are supposed to treat pain and disability and establish a sort of relationship and with the patient to aim restoration of full functional capacity, not only making patient free of pain. Psychological approaches include psychoeducation. That includes telling the patient what this disease is, what are the likely prognosis, and how it will change with the treatment, what benefits he or she will get, and how to look into the associated issues of psychosocial domain. As far as clinical depression or anxiety is concerned, we have multiple options of treating such patients with or without rheumatic diseases, and there is no bar in giving good dose of a very good antidepressant or anxiolytic. But if the patient is suffering from a sort of depression which is difficult to manage, then such patients can be referred to a psychiatrist. Cognitive behavior therapy is the second main goal of treatment of such patients, and this includes identifying negative thoughts about the illness. Many patients, they start thinking there is no treatment for such patients. They keep on processing such thoughts, and that results into break in the treatment process. And if they start treatment, there are many factors which will hinder such a decision. Any person can suggest these medicines are addictive, these medicines will destroy your immunity, this medicine will cause obesity. All these issues should be addressed and properly treated. And then there is a tool we call coping skill training, and they have been found effective in treating such patients. Coping is a process of responding to, managing, or contending with life stresses and difficulties. They can be of two types: adaptive, maladaptive. Adaptive coping is problem-based coping or emotion-based coping. Problem-based coping means to solve the actual problem. I mean, making the patient pain-free. If he has developed some disability, the problem is in walking, the problem is using stairs, and the easy solution to that is to arrange a wheelchair, if he or she can afford, can have an automated wheelchair, or if you cannot support, can have a simple machine, but that will actually solve the problem, and solving the problem will result in decreased stress and more functional capacity. And the maladaptive coping things are the patient denies the illness or avoid thinking about the illness and say it will automatically resolve and do not take any essential steps. Many patients, after once or twice they got treatment, get better, and they relapse, and they start losing hope that it is an endless story. Then they think the disease is not under control. then there is a tendency to catastrophize the illness. During acute phase of illness, patients usually think that this is the end of the story. I'm going to die or I'm going to have a permanent disability. So these thoughts, these emotions should be addressed in time. And then our main job remains to break this vicious cycle. Chronic fatigue, pain results in negative thoughts and emotions, and then there is a fear of progression. Many patients, they withdraw from social activities and they keep confining themselves to the bed or their home environment, and that results into depression. This cycle keeps on going till we break it at different levels, and that's a success story. To do all that, we need passion. This is a passion flower. We all need a passion to treat patients like the passion Dr. Tafazli Mahmood have. Thank you very much.